Welcome back. Today we have Neel Devi, who is a 75-year-old male who is complaining of fainting, dizziness, general weakness over the last week and passed out about an hour ago before coming to the ER. So let's get started. As always, we want to perform a focus interview with our patients on why they are here. You can see the questions asked via the text bubbles now and the responses. This will be the initial information to guide our treatment. We will now attach our vital sign monitors and start an IV. Here you can see our vital signs currently. This patient is experiencing symptomatic bradycardia. Let's get a 12-lead EKG to get a better idea of what we are dealing with here. After reviewing the 12-lead EKG, we can see that this patient is in a blocked rhythm, and this may prevent us from using the typical IV push treatment. Anyways, we will gather a glucose, troponin, a venous blood sample, and an arterial blood sample as well. If we take another look at our vital signs, we can see that this patient fits the bill for the adult bradycardia with pulse algorithm. Here, step 1 states that traditionally the patient will manifest with a heart rate below 50 beats per minute, and we are currently sitting in the 30s. Step 2 will ask us to identify and treat any underlying causes in the form of the patient's airway, oxygen, cardiac monitoring, IV access, and a 12-lead ECG. Step 3 wants us to determine if this is a persistent bradyarrhythmia with signs of hypotension, altered mental status, shock, chest discomfort, or acute heart failure. Looking back at our vital signs, we can see that this patient is hypotensive and has signs of shock. Mr. Devi is not exhibiting altered mental status or reporting chest discomfort currently. As such, we will go to step 5 and prepare to administer atropine IV push. Please note that if atropine is ineffective, we will need to start transcutaneous pacing. In addition to atropine, we will start a bolus of 1 liter of saline in a saline bag at 75 milliliters an hour, IV now. We will now give 0.5 milligrams of atropine IV push and wait a few moments to see if we get a response. After about 15 seconds, we have not had any improvement, and we'll give another dose of atropine at 1.0 milligrams of atropine IV push, and again wait to see if we get a response. Unfortunately, this is not working, and we will need to give procedural sedation and begin to pace this patient up to 60 beats per minute. We will take a quick listen to the lungs and the heart. Our staff reports that they don't hear anything wrong with the heart, but that the lungs sound as if there's crackles at both bases and that there's a lot of noise coming from the airway. As such, we will observe the airway, but don't see anything abnormal. We will obtain a chest x-ray to determine if there's something in the throat in the meantime. Additionally, since we sedated the patient and they will need to go down to the cath lab for a pacemaker, we will insert a urinary catheter. We will repeat a 12-lead EKG and then transfer our patient to the cath lab for transvenous pacing. You will note that the American Heart Association requested that we should have auscultated the lungs sooner than we did, but that otherwise everything was spot on. If you would like to review any of the timestamp data here, feel free to pause the video at any time. Thank you for watching. If you enjoyed this content, consider liking the video. Leave us feedback in the form of a comment if you have any questions, concerns, complaints, or compliments. If you want to see more content like this, consider subscribing to see more footage like this. Till next time, stay safe.